everybody's talking. What's everyone talking about, Whip?
I think they're talking about ChatGPT.
ChatGPT. Yes, that's what they're talking about. Yes. And so I thought like we could do something about ChatGPT.
Okay, let's go. Let's do it.
Which is like, let's compare the knowledge between ChatGPT and our resident expert, who doesn't like to be called an expert, Dr. Wiplove Lamda. And where are you licensed to practice?
I mean, I'm board certified in the States for both psychiatry and for addiction and medicine. And in Canada, I've got the Himfelder Royal College of Physicians and Surgeons for Psychiatry, and I have an area of focused competence in addiction medicine.
Fantastic. So what I did is I picked about 8 or 9 questions, and so I've got the questions here in these envelopes, sealed envelopes. And
have you told me what these questions are beforehand?
Have I told you what these are?
No, I don't know what these questions
That's right.
are.
So you swear you've not seen these questions before. Is that right?
I've not seen those.
This is the first time you're hearing these questions.
Yes.
So you've had no time to research?
Well, not these questions, but like I have a job that I do every day that includes working with people who use drugs.
Right, but not these particular questions. You don't know what's going to happen.
I don't know what's going to happen.
Okay.
You could ask me anything right now. I have no idea what it's going to be.
So I've got the question on the outside of the envelope, which Rick has not seen.
I have not seen. Yeah.
And inside the envelope, I have the answer from ChatGPT.
So sometimes they have like 50 sentences. They have like
sometimes
30 pages.
Sometimes. So we had to pick answers and questions that kind of fit into this little format. So this podcast didn't go on for 7 hours.
Okay.
All right. You good?
Yeah. Good.
All right.
Let's do this. Let's go.
All right. So let's start with the first question.
Should I take a deep breath or something? Like get myself in my work
do you need to do some calisthenics? Do you need to do some push-ups? Anything?
I don't know.
Like
I think. Let me just try to clear my mind.
All right.
Let me think. I should have a chant or something. Before I get into work mode.
All right.
Let's go.
Here we go.
Yeah.
So ChatGPT's knowledge base is capped at September 2021.
Oh, I didn't know that.
Yes.
Oh, wow.
So any question that's asked is dated as of the knowledge at September 2021. So I'm going to ask you to kind of go in your own virtual time machine here to September 2021. So
wait, when was that? Was that
about 18 months ago?
Oh, I don't even remember what happened yesterday.
Well, there you go.
Oh my.
All right.
Okay.
So I'm just going to give that.
I did not.
That
I did
qualifier.
Not. I did not know. Yep.
So the first question is.
Okay.
Drum roll. As of September 2021, is there a FDA-approved medication for cocaine use disorder?
No, there's not.
There is not.
There's not. There's none today either.
Okay. All right. All right. Let's check the answer here.
I thought you were getting me like those paragraphs, like how do you help somebody with this, or how do you? I thought it was gonna be like a page answer.
No.
It's like a Jeopardy kind of thing.
This is proof you haven't seen the questions before.
Okay.
All right. So, no, there was not.
Okay, good.
Some medications have been studied for treating cocaine use disorders. And for bonus points, some of these medications would be
like topiramate, bupropion, stimulant medications have been studied.
And difusiram.
Yeah, but that's disulfiram.
Disulfiram.
Yeah. So disulfiram is mainly used for alcohol use disorder. That's the old medication called antabuse. So whenever you talk to a patient, do you want a treatment for alcohol use disorder? Do you want a medication? Like, no, I don't want the medication that you get sick from. And they don't realize that that's the one that's been used for a very, very long time. The reason is because theoretically, the way it works in the pathway for breaking down, it's supposed to increase dopamine. But in real life, I've never used it for that purpose, especially because if somebody drinks, if somebody has a dessert that has some of those like liqueurs in it, they just get super, super sick, right? And so usually we use off-label topiramate for it, and there's some other ones too.
So when they say that they're being studied, that means there's some research but no evidence?
No. So what it means is that there have been some randomized controlled trials, case reports, case series that look at people that have these diagnoses and whether or not the medication works. In order to have something FDA approved, you have to have a certain level of evidence, right? So you can't have a study with like 100 people where 50 people have the disulfiram, 50 people don't, and then a certain percentage are better than otherwise. You need a robust set of data to get something FDA approved.
So completely evidence-based. It has to be definitive.
Well, let's be honest, right? I mean, these studies are all complicated with conflicts of interest and biases. A lot of times it's the company that has the funds for the drug that'll make money off it that runs the trial. And there's a lot of things with lobbying and things like that occur as well.
But the concept is that FDA approval is a higher standard
than just one study. Yeah, than one study, right? And so for those other drugs, whatever were on there. Yeah, okay.
Go ahead.
Well, so I guess it's a tie, right? We're both good.
Yes. So here's our sound effects. By the way, it's a low budget sound effects, but here we go. We have a tie.
Yeah. Although I paused before the disulfiram, right? Just because I never.
Yes,
used it,
that
right?
was more for the bonus points. The question was just
fair enough.
Was just on this. Was this on that thing? All right. So far it is. It's a tie. We're at 0-0.
Yeah.
All right. So now we're going to get into a harm reduction question.
Okay.
Okay. And this may be familiar to some people and maybe an odd question for others. So in harm reduction, people are often, again, it depends on what community you are, and certainly this will be more foreign to our people in the States that are watching. But people are given free needles. People are given supplies to inject. But a lot of people inject tap water instead of
saline.
Instead of saline. And the question is, why is it dangerous to inject tap water into your veins?
That's a good question. I mean, it has a different concentration than your regular blood does, right? In terms of the sodium concentration, and so it'll change sort of the osmosis thing. I just think there's a high risk of having certain infections, certain bacteria, things like that would be in it. But I don't actually know. So let's see what it says.
So infections? Bacteria?
Infections, bacteria, and also like the what do you call? There's something with the osmolality and the tone of it, right? And it can really affect the person in the brain. Yeah, I don't know. I'm gonna have to look this up, but yeah.
All right, let's see what Dr. ChatGPT says about this problem.
Let's see.
Injecting tap water into your veins is extremely dangerous for these reasons. Infection risk. Tap water is not sterile and may contain bacteria, viruses, and other pathogens. Introducing these contaminants directly into your bloodstream can lead to serious infections, sepsis, and even death. Chemical contamination.
Ooh, chemical. I didn't say that.
Tap water can contain trace amounts of chemicals such as chlorine, heavy metals, other impurities in such cases. These chemicals can cause more severe systematic reactions and organ damage.
Okay, so yeah, I didn't say chemicals.
So I don't know. I think you did pretty well.
Give it to them. You think? That's fine. Yeah,
you sure?
Yeah, let's be fair. Let's be fair.
All right.
I mean, it's like I think of a better answer. I think it's like a.
And the winner is ChatGPT.
It's like a 40 second.
Yes, it is. There's actually 53 different contaminants in the Toronto city water that you can get an infection from. Very old school question that folks in addiction have been studying for a long time. Is there evidence that addiction can be genetic?
I mean, the challenge with a question like this is that it's always very, very complicated, right? It's that whole nature versus nurture. And even now with epigenetics, there's a lot of talk about nurture changing your nature. Mm-hmm. The thing that is very clear is that if you have a family history of a substance use disorder, so alcohol use disorder, opiate use disorder, any one of those, but alcohol I think has the strongest genetic connection to it. You're going to be at much higher risk for having it, right? And so sometimes, when you have certain people where their fathers or mothers were heavily dependent on alcohol, and they make that decision never to try, their almost lives are likely to be better by that decision, than in terms of the risk of developing alcohol use, right? There's a very, very strong genetic component. I don't want to put in numbers because, in the research, they have all these things where they look at different SNPs or different genes, and a lot of them, there's certain ones that are very clearly correlated with the risk of developing a substance use disorder. But the thing I'd like to just sort of make very, very clear is that there are signals now coming out that, early trauma, early stress can actually change your epigenetic profile to make you more vulnerable to develop addiction. So they talk about nature versus nurture, but there's strong signals now that are coming out in literature that by your early experiences, you can change your nature and that risk to develop an addiction from a clear biological perspective.
Yes. So right. So let's see what ChatGPT said here. And yes. So this is a tie. So yes, there is evidence that it plays a role in addiction. I did some research independent of ChatGPT as well, and looked at there's some twin studies that happen, twins that were separated at birth, to verify that. And it backs up ChatGPT's number, which is, it says the predisposition accounts for approximately 40 to 60% for developing a substance use disorder, which you said in some cases there is that.
Did I say the number 50?
You didn't say a number, but you said there are some.
Sure.
And I would say some is that. And genetics is an important factor, but it's not the sole determinant in addiction. These studies have found that individuals with a family history of addiction are more likely to develop substance use disorders themselves.
Okay.
All right, so that would be a tie. We have a tie.
So maybe you should let me talk, then push the button, then read the answer, and then we can argue it. Let's try. Do you want to try that?
All right, let's do that.
Yeah, let's go.
Okay. Can methadone be addicting?
Yes.
We have a tie.
Should I put qualifiers in that, or should I just?
Well, we can go to their answer, and then you can maybe add to their answer. How about that?
Yeah, sure.
We'll try that format. Okay, methadone is a synthetic opioid that is used in medication for treating opioid dependence, specifically for those addicted to opioids like heroin and prescription painkillers. It can help reduce withdrawal symptoms, cravings, making it an essential part of medication-assisted treatment, MAT, program for opioid use disorders. While methadone can be an effective treatment option, it is also an opioid itself and has the potential to be addictive. Methadone can cause physical dependence, which means that the body adapts to the presence of the drug, and withdrawal symptoms can occur if the drug is stopped abruptly.
Yeah, and I think it's very important to clarify what methadone is and why it's so helpful for people. And so they say a drug is addictive. The more addictive a drug is relates to how fast it works in your brain and how long it lasts for, right? So drugs that work quick, fast, and go to the system quickly are more likely to be addictive than ones that aren't. And with methadone, the value in it is the really, really long half-life, right? So if you're using opiates, heroin, fentanyl, usually you have to use multiple times a day to avoid withdrawal. With methadone, you can get away with once-a-day dosing to avoid it. And the other thing is because the receptors are saturated, if you use on top of it, you don't overdose and die. But it does cause a physiological dependence. It can cause a psychological dependence, and you have withdrawal when you stop.
And can you speak to why some people say it's not a good idea to sort of get off too quickly? Can you add to that?
Yeah, absolutely. Yeah. So basically with opiate use disorders, what they find is that the relapse rate is really, really high, when people stop and then they detox. And so it's above 80 to 90% within the first year. It's higher than that if you go further down. And what commonly happens for some people is that they stop using, they come off of the opiates, and then their system resets, and then when they use again, they're lost the tolerance, they overdose and die. And the withdrawal is horrible, right? So what happens in the withdrawal, you get like sweaty, you get a runny nose, you get teary eyes, you get diarrhea, you get nausea, you get muscle twitching, and you get a lot of psychological symptoms like suicidal thoughts and depression. It's a horrible couple of weeks for anybody.
Okay. And if you had somebody in your office that was a stable patient that was on, say, 80 milligrams of methadone daily, and they were committed to, they said to you, Doc, I really want to move free of this medication. What would be a safe timeline for me to go from this 80 to nothing?
Well, the thing I mean, at the end of the day, we have to do what the patient wants regardless, right? I think that's, it has to be very, very patient-centered with some limitations to it. The thing to remember is that the World Health Organization or the American Society of Addiction Medicine, they really recommend, 1 to 2 years of stability before tapering down. So to let the person know that, if you want to taper down, you can. We just need a certain time of stability first, right? And ideally, I'd rather you work on getting your life together than getting off of this daily medication first. Usually, they say 5 to 10%, every couple of weeks, sometimes even less. But I think you have to do it very person-centered.
Sure.
And for some reason, there's a lot of pride in some people of toughening it out at the detriment of them trying to improve their life in other areas, right? But I think you have to take it as a personal basis. I don't think there's a one-size-fits-all kind of.
So the question is, which you're already almost sort of answered, can Warnicke's syndrome be cured?
Yeah, so it requires a high dose of thiamine, right? And so when people aren't drinking, they come to hospital. Usually, you'd give them maybe an IM injection of.
We have a tie. Go on.
Yeah.
Oh yes, now I'm supposed to open this.
Oh, you already knew the answer. I guess you.
Oh yeah. Yes, I did know the answer.
Yeah.
Yes, Warnicke's encephalopathy, also known as Warnicke syndrome, can often be successfully treated if caught at early stages and managed appropriately. The primary treatment involves the rapid administration of thiamine, vitamin B1, usually given intravenously. This is something we give in our detox as well, not intravenously, but orally.
It should be IM or intravenously. Yeah. People can absorb the stuff.
This replenishes the body's thiamine strongly. The body's thiamine stores, addressing the deficiency that can cause the condition. Early intervention is critical, as delayed intervention can lead to irreversible brain damage and the development of a more severe complications such as Korsakoff syndrome. In addition to thiamine supplementation, it is important to treat the underlying cause of the deficiency. This may involve addressing alcohol abuse, malnutrition, and other factors that contribute to the development of Warnicke's encephalopathy.
Yeah. So this is an area that I think is unfortunately missed quite a bit. Someone comes in, they're intoxicated, a little bit confused, and then people might order thiamine for it, and it's something that we really underdose. And the thing that I think is important is that only about a third of people with Warnicke's encephalopathy have the full triad. Right, and so when they look at large population data, it's some people have one symptom, two symptoms. Not everybody has all three. So I think the thing about this condition is that I think we definitely undertreat it. And so even though they say it can be permanent, when you look at articles, they'll talk about how if somebody has significant deficits, if you keep giving them thiamine, a small percentage still get better, right? And so I think for everyone who drinks, it's good to have a little bit of thiamine.
So not to get very dark and personal about this, but my father he owned a number of taverns when he was alive. Now he's dead, but he didn't eat. He would start drinking at 11 a.m. Every morning, and his wife would make a beautiful meal at like 10 o'clock at night, and I didn't see him eat for I understand he hadn't eaten for months and months and months and months. Yeah. And I've told a few people that, and they said that's not impossible. It's not possible, but it's in his case it was. And he hadn't been to a doctor, and he never went to a doctor. But he didn't. Who knows how that manifested itself? But he didn't recognize people. He didn't. He thought last time I talked to him, he said, I just talked to you like 3 weeks ago. I said, you haven't talked to me for 15 years.
Yeah.
And, is a lack of nutrition like a contributor to
of course.
Yeah.
That's why it's not that they're drinking, it's that they're not eating.
Okay.
right? And also when they're drinking, something happens to the gut where even if you are eating, you don't absorb the nutrients.
Okay.
The challenge is, I mean, the memory could be related to that, but it could be related to other things too, right? So
course.
Alzheimer's, short-term memory is very, very common, and then you can have that overlap. And then the other thing is, when people are drinking heavily, they can have other things too. They can have high blood pressure, hypertension, heart disease, and that also contributes to vascular things as well. So a lot of times in hospital, we'll get people that have that full sort of triad of things, where they have some sort of mild cognitive impairment. Maybe they were a little bit scattered before, they've had the heavy drinking, and then on top of that, they've got some vascular changes in the brain. And I think this is why a lot of public health people were pushing for just include it in the beer. They like to just put the multivitamins in the beer. Why not have it in the beer? And it never got to that point really, but why not? Why not? I mean, people don't know about this stuff, right? And even if you start taking the oral vitamins, but you're not eating food, you're still not going to absorb them as well, right? You need to have them with food to absorb. And just like some of the other stuff that we've talked about, like so now we're a lot better when somebody has a stroke, when someone's eating like fatty foods or cigarettes, they know about the harms related to it. Not everyone knows about the memory deficits that can occur with alcohol, right? And then what can be done to mitigate those risks.
Yeah, one of the challenges that that I see in the work that I do is that the individuals that I support are obviously very heavy drinkers and have a lot of complications from that drinking, but they also don't have any attachment to medical care. So their only interaction with something that's, I don't know, quasi medical or half medical or whatever you want to call our what a detox is, on depending on which day and which site you're at. But you know, that's all they're going to get.
Yeah, I would love it if go ahead.
And I see this cognitive decline.
Of course.
And now with we have made some progress because thiamine is not a anyone can order it now.
Yeah, it's over the counter.
We don't give out aspirins, we don't give out Tylenol, even though those are over the counter too. So those need to be approved by our prescriber.
Yeah, no, but that's part of the organization, right? That's an organizational thing.
Right. It's not. It is an organizational thing. But now, as the organization, we will give thiamine to anyone that asks for it. And offer it. Anybody can. Anyone in our center.
Yeah, they should do it. They should do it. IM if you can find a way. I mean,
yeah.
I know. There's limits. When you do get to an injection point, but when people are drinking that much, their gut doesn't absorb it, right?
Yeah.
And so it'd be nice to have the IM 200 would resolve any deficits in thiamine people have with it, unless they have Warnicke's or Korsakoff. So.
All right.
What's next?
Next is for elderly patients.
Yes.
Elderly patients that have alcohol use disorders. And they're going through alcohol withdrawal, which means they stop drinking. Which medication is safer, Valium or lorazepam, and why?
Okay, so you're throwing me little lobs, right? Yeah. So lorazepam is safer and really has to do with the short half-life and the lack of metabolites. So diazepam has multiple metabolites, and the more that you give, the longer it lingers, and the metabolites keep working and working as well. What ends up happening in alcohol withdrawal is you get a bit of delirium, right? You get a little bit of confusion, and lorazepam and Valium can prevent it. But what happens when you use Valium, it lingers for so long that it's more likely to lead to a delirium piece afterwards.
And the winner is Dr. Whip.
Oh, you picked that on purpose. You probably did 20 questions. Which one would Whip get a better answer to?
No.
Okay,
it's so it doesn't. It states that it gives the reasons you gave, but it won't state which would be safer for that. It says in terms of safety, it says both Valium and lorazepam have side effects such as drowsiness, confusion, and dizziness. However, there are some differences between them, which may influence which is safer. And but it doesn't call it.
Yeah, well, I mean, the challenge is that it's if you don't have any liver problems, right? You don't have any sort of memory difficulties. You're not drinking heavily, then it probably doesn't matter which one which you get. But as you get older, it's more likely that your body's going to be a bit more frail. It's not going to be able to metabolize things better. And in fact, my boss is really pushing for lorazepam for everyone who's elderly who comes in. The reason diazepam is better is that if you're at high risk of seizures...
Diazepam being Valium?
Yeah, Valium, yeah.
Okay.
If you're at higher risk of seizures, like you're drinking more than 8 to 10 standard drinks a day, you're doing it daily, you're doing it for multiple weeks, Valium's much better at covering the risk of seizures than lorazepam. You have to keep dosing lorazepam.
Just because we covered this, unfortunately, in an earlier episode, I asked you to give a medication name, but is Valium is a brand name? Is that why we're having trouble saying the name? Is that why?
Well, not Valium. Well, I mean, it is a brand name, but I don't know how much money people come from it. I think one thing that's happened to us is that you've been using name brands, and when medical professionals give any kind of talk, you're not supposed to say the name brand, right? And a part of it is just they say, so it's a conflict of interest, it's like advertising bias, that kind of stuff. The challenge is there's certain medications that only have a name brand version, right?
Mm-hmm.
So anyways, but that's fine.
And we're trying to cover stuff that everyday people know too, right? We're not just trying to get into...
Yeah, like it's one of the things where, I mean, if you know something's Tylenol, you know something's Tylenol, right? Like if I kept saying acetaminophen, and when I take acetaminophen for my headache, and they're like, is he talking about Tylenol? Yeah, I'm talking about.
So I hope we don't get like in trouble with.
Well, you won't get in trouble.
Police,
you won't get in trouble.
But you might get in trouble.
Yeah, we'll see. It could be a bias conflict of interest. I might have to put it as a disclosure that I've given podcasts before where I've used brand names.
Will this be worse than your parking ticket?
God, I don't even care about the parking ticket, to be honest. I just...
All right, next question. You ready?
Yeah.
All right, good. Why is opiate withdrawal so problematic for expecting mothers?
Well, that's a great question. And it's actually a controversial answer, because if you ask, what's the thing where you ask 10 dentists?
Yes.
If you ask 10 obs-gyn doctors, not all of them will say this, right? So I believe, and I might be wrong. I mean, my colleagues Suzanne Turner and Erin Lurie would know much more than I do. Alice Ordine, the people that do pregnancy and addiction. I believe it increases your risk of preterm labor and also delivery complications.
Yes. Any others?
Yeah, I don't know all the others, right? Like, maybe placenta rupture.
Well, let's think of another that isn't just because they're a mother. Maybe perhaps that question would be a little.
Oh, you're helping me out.
I'm helping you out a little.
That's good.
So
that's good. So withdrawal can cause mood symptoms. It can increase suicidal risk. It can increase depressive symptoms.
And just the obvious one of risk of relapse, obviously, is.
That's
for everybody. It's not just an expected.
Well, yeah, I think even if you're using, it's okay.
Exactly.
Yeah, fair enough. Okay, thank you. Yeah.
We have a tie. Is it weird that I really like this music?
Well, I mean, you spent some time picking it, right? I'm sure you, with the meticulousness you have, I'm sure you listed.
There's some development involved. Yes, there is some there's some downloading involved, but also some.
Well, I mean, it's like a lullaby, right? So it's like the world is safe. GPT will help me enough.
Exactly.
Right, yeah.
All right. So next one is building on to why I kind of cut you off on your earlier answer, but which medication has a higher likelihood of overdose? Methadone or Suboxone, and why?
Yeah, so methadone has a high risk of overdose than it just has a high risk of overdose, and the reason is because it's a full opiate agonist. And
we have a tie. Playing this until you hate it so much that you just throw your microphone.
Yeah, so it's full opiate agonist, and the other reason that's really tough is because it stays in the fat tissue, right? And so what happens in the fat tissue sort of lingers and creeps out, and the treating dose is very close to the toxic dose, right? That's what makes it so dangerous, and that's why they have very rigid regulations when you can take it. Whenever they start prescribing methadone does lead to overdoses in regions due to diverted amounts. Buprenorphine, should I just let you read the answer instead of me talking, or should I read?
No, you're doing good. You're doing good.
Yeah, with buprenorphine, it's a partial opiate agonist, and so it binds the receptor, but there's a ceiling effect for respiratory depression. So I take a whole bunch of buprenorphine, even though I'm naive, I'm not going to stop breathing. If I take a little bit of methadone, I'll probably stop breathing.
Okay. And is the injectable buprenorphine even safer than both?
So it depends. That's very important. So with the injectable buprenorphine, not many people know this. If you're a patient, you can't actually go and pick it up from the pharmacy.
Right.
And the reason is because if you put it in your bloodstream, you'll die. So what you need, a physician has to go pick it up. They keep it in their office. A person comes in, and then you give it to them in the subcutaneous fat for the injection, right there. And so in there, that's how it that works. Leaves a little bit of a lump. It lingers for a little while. I mean, I think it all depends what you mean by safer, right? So in terms of if the person's not
Well,
overdosing,
in the terms of overdose, which was the
yeah,
question.
so overdose in the next, month, obviously the injection is safer because you're sure it's in the system, right? Whereas for the sublingual one, you have to take it every day. But if it's around the risk of sort of like infections or like pain or stuff like that, maybe
Okay.
under the tongue might be safer. Thing.
The next question, which is the last question.
Okay.
Does the overdose reversing drug, naloxone, provide any benefit to patients that are overdosing from crystal meth or benzodiazepines?
Yeah, I mean, this is tricky. I mean, only if they're also taking opiates.
So in the
Like it
for the
doesn't help. I
purposes
don't
of
think
this
it
question,
doesn't help at all.
let's assume there's no commingling of the drugs.
Yeah, I'll say no. I'm going to say. I mean, it helps the It helps the healthcare provider know that there's no opiates in the system.
So the question is, it's a yes or no. Does the overdose reversing drug naloxone provide any benefit to patients that are overdosing from crystal meth or benzodiazepines on their own? So let's just assume
Patients, no, it doesn't help them at all.
we have a tie. Yes, so that is correct. In summary, naloxone provides no direct benefits to patients overdosing from crystal meth or benzodiazepines. However, it's essential you call emergency services to help in these situations. And this is a real problem these days because of the certainly in our market because of the contaminants in our drug supply. We see something like I was reading. I think it's 68% of fentanyl has benzodiazepines in it now.
Yes.
And so sometimes when we give this drug to revive people, it doesn't work, and because it's it doesn't work because it's not reversing the benzodiazepine, and that's a really sad time.
Yeah, I don't know what we can give, right? Because they do theoretically, when you read textbooks, they'll talk about this thing called flumazenil, right? But the problem with the flumazenil you give to somebody who's physiologically dependent on benzos, what happens to them? They have a seizure. And so how do you get these people breathing again? And I'm not sure. Sometimes if you keep giving naloxone, eventually you get enough of the opiates off that they start breathing again, right? And so some of this fentanyl that's mixed with the benzos and the xylazine and all that stuff, they'll do 4, 5, 6 doses, then maybe the person starts breathing in when you have enough of the opiates off, but it doesn't touch the benzo overdose. And then the crystal overdose is interesting too, right? Because when crystal came out, at least from some of the podcasts we watched, around the party and play stuff, it was very clear that the overdoses were going nuts, right, when crystal came around, right? And partially it was related to whatever G and other things as well. It's a different kind of overdose experience, and what's happening in Ontario now. The emergency visits for crystal are also going through the roof, right? Like several 100% higher than they were a few years back. And I'm not sure what that means, right? At least with opiate use disorder, you can say that, you provide medication-assisted treatment like they call it in the States, or opiate agonist treatment like they call it here. There's a certain percentage of people, a high percentage of people that have less risk of dying. But we don't have anything good for stimulant use disorder.
No, we don't. We don't have anything good from
a medication standpoint.
In either reversing the overdoses or treating them, and that's a real.
Well, I mean, there's a couple of things they do, right? So I mean, not necessarily reversing the overdose, like if their heart stops, right? But if they're on a very high mount, their heart's racing and all that stuff, sometimes giving benzos is helpful to protect their heart if they're like really, really agitated. And then there's other strategies to bring down their blood pressure and their heart rate and treat the psychosis if they have it as well.
This is in hospital we're talking about.
Yeah, this is in hospital, but outside of hospital, I don't know what to do.
There's nothing.
Like when people overdose from stimulants, is it just is mainly you see their heart stop, or what have you seen or heard when people overdose?
So it's so hard for me to say what I've actually seen and not seen because we don't know, right?
You don't know what's in their system,
so
right?
We don't know that, right?
Yeah.
So we, when a gentleman that I was involved with that ended up passing away, I was shocked at how little investigation was done in any part of it. That's a sad part for me, right? Where
you mean the coroner's report? They didn't check what was in. You don't even know if there was. Well, we wouldn't find out, right? We're not like I don't know when people have ended their life. It's rare. Sometimes I'll find out serendipitously.
So on the question of how do you think? Do you think ChatGPT did okay?
Well, I think the challenge is that you put in factual questions, right? Which is good. But the magic with ChatGPT or whatever it is, I don't think it's in the facts. It's in like
The nuance.
well, the nuance and the expert opinion. And I've been
Isn't that
blown
what the
away.
magic of doing what you do is the nuance?
Well, I think we'll be surprised. Like if you said like, "Hey, ChatGPT, how do you help somebody with an addiction?" Hey, ChatGPT, like, say your friend is using alcohol, what can you do for them? We're gonna be blown away, right? Because the thing is with facts, like we could have been doing Wikipedia searches, right, and had the answers, which is fair.
Maybe someone will put that in the comments as a criticism. Why don't you just look at Wikipedia?
No, but I mean, I think the idea is great, and I thank you for being gentle with me because like I know the things that are top of mind, but I don't know those other things, right? And even with the saline and the water question, I was like, oh, I'm not sure what all the specific risks are. I'm just like, don't do it, and
Don't
use
do
this
it.
instead, right? Use this instead. Here, use this instead. So yeah, no, it's I think it's gonna be a phenomenal tool. I've played with it a little bit in terms of like those healthcare questions like, oh, how do you help someone with this, how do you help someone with that, and the answers are really like quite impressive for it. I've even seen a couple of YouTube videos where docs are like looking at it and just like analyzing the answer and stuff, and I don't know.
All right. And you did learn that September 2021 was the cutoff date, so if anything major was announced in the 18 months since then, it wouldn't be covered in ChatGPT because
absolutely.
Yeah, so maybe they'll be updating that. All right. Well, thanks for checking it out.
Okay. Thank you.
Bye. Thanks for watching. If you like what you saw, please feel free to like and subscribe. That way you'll get notified when we come out with new content. We try to come out with new content about every week or so. So anyway, thanks again and see you soon.